Hello guys, welcome back to my channel. In this video, let's see about the 3 surgical treatment options for primary weight loss and their complications and side effects. Obesity is a chronic condition characterized by an extreme accumulation of fat that exceeds the body's skeletal and physical standards. Morbid obesity, which involves an increased risk of coexisting disease, is defined as having at least 100 lbs of excess weight, being 20% or more above your ideal body weight, or having a BMI of 35 kg per meter square or higher. At this stage, obesity becomes a health risk and treatment options must be contemplated. Weight loss or bariatric surgery is considered for the morbidly obese patient when all conventional therapy, including behavior modification, diet therapy, exercise and medications has failed. But before going into the surgical treatments directly, let's have a small discussion regarding stomach. The stomach is a muscular organ located on the left side of the upper abdomen. The stomach receives food from the esophagus and serves as a temporary receptacle for the storage and mechanical distribution of food before it is passed into the intestines. As food reaches the end of the esophagus, it enters the stomach through a muscular valve called the lower esophageal sphincter. The stomach secretes acid and enzymes that digest the food. Ridges of muscle tissue called rugae line the stomach, which disappear when the walls are distended. The stomach muscles contract periodically, churning the food to enhance digestion. The pyloric sphincter is a muscular valve that opens to allow food to pass from the stomach to the small intestine. The human stomach is subdivided into 4 regions: the fundus, the body, the antrum, and the pylorus. The fundus is an expanded area curving up above the cardiac opening. The body or intermediate region is the central and largest portion. The antrum is the lowermost and somewhat funnel-shaped portion of the stomach. And the pylorus is a narrowing where the stomach joins the small intestine. Each of the openings, the cardiac and the pyloric, has a sphincter muscle that keeps the neighboring region closed, except when the food is passing through. In this manner, food is enclosed by the stomach until ready for the digestion. Surgical treatment options. There are currently 3 primary weight loss or bariatric surgeries being performed. They are Roux-en-Y gastric bypass, adjustable gastric banding, and sleeve gastrectomy. All of these surgeries have pros and cons to them, and none of them are a quick, simple fix for losing weight. With each procedure, you must follow a diet and exercise program in order to have good results. And surgery is just a tool to assist in the weight loss process. Restrictive surgery limits food intake by making the stomach smaller. Malabsorptive surgery hinders the calorie absorption by shortening the duodenum and or alternating where the duodenum connects to the stomach, thereby limiting the amount of food digested or absorbed. The third type of surgery is a combination of the first 2. Restrictive procedures, which are performed least often, result in the most significant weight loss by reducing the amount of food eaten and slowing the speed of gastric emptying. Roux-en-Y gastric bypass. Of the 3 procedures, gastric bypass surgery has been performed the longest. A small pouch is created by separating the stomach into 2 sections. Both the pouch and the unused portion of the stomach are closed with the staples or a band. The small intestine, which produces digestive enzymes necessary for the breakdown and the absorption of fats and proteins, is reconnected to the pouch, bypassing the duodenum, jejunum and all but the last section of ileum. Because much of the small intestine is bypassed and the amount of food exposed to the digestive enzymes is limited, very few fat and protein calories are absorbed. As a result, malabsorption occurs. Initially, this procedure results in the greatest percentage of weight loss, with a maintenance loss of about 50 to 60%. The operation takes about 4 hours and involves a hospital stay of 3 to 5 days. Negative effects of the procedure includes vomiting, second surgery, leakage of the Y connection between the pouch and the duodenum, and the gallstone development. The bypassed portion of the stomach is difficult to see on the radiographs. A reaction known as dumping syndrome occurs when the contents of the stomach move too quickly through the small intestine, resulting in nausea, weakness, sweating and diarrhea soon after eating, and extreme weakness after sweets are consumed. Pregnancy should be avoided until the weight loss has been achieved and the patient's weight is considered to be stable. Adjustable gastric banding. Adjustable gastric banding is purely restrictive surgery. It involves a surgeon placing an adjustable silicone band around the upper part of the stomach. Of the 3 procedures, only gastric banding is adjustable. The amount of food a person's stomach can hold can be altered by adjusting the tightness of the band around the stomach. It offers the advantages of being adjustable and reversible. This type of surgery is easier to perform and has a lower complication rate than malabsorptive surgery. The surgery, which usually takes about 1 hour, is done on the outpatient basis and involves an overnight stay. After small incisions are made, a laparoscope is used to visualize the placement and to suture an adjustable hollow silicone gastric band around the top 5% of the stomach and creating a smaller upper pouch and a larger lower pouch. No staples are used. The band is connected to the port that is placed subcutaneously in the stomach via small incisions. The port can be accessed to inflate or deflate the balloon in the band, which changes the size of the band accordingly. The diameter of the band obstructs and restricts the passage of the food. The band is inflated or adjusted by adding saline to or removing it from the port. As the patient eats, the upper pouch fills and the patients feel full sooner. The pouch initially can hold about 1 ounce of food but later expands to hold up to 3 ounces. The normal digestive procedure is not altered, and most patients return to normal activities within a few weeks. Post-surgical instructions include a liquid diet for about 2 weeks, followed by soft foods and then solid foods. It is highly recommended that the patient follow a personalized nutritional plan and exercise program. Within the first 2 years, there is a weight loss of about 50 to 60%. Sleeve gastrectomy, and this is purely malabsorptive surgery. This involves a surgeon removing 80 to 80% of the stomach, then stapling the remaining portion of the stomach together. This is a restrictive procedure that limits the amount of food you can consume. In bilipancreatic bypass with duodenal switch, the stomach is reduced and the small portion that remains is connected directly to the end of the ileum, thus bypassing the duodenum and jejunum entirely. This procedure is performed infrequently because of the high risk of nutritional deficiencies. Criteria for surgery. To be a candidate for weight loss surgery, you must have a BMI or body mass index greater than 40 or a BMI greater than 35 with comorbid conditions, meaning other medical conditions such as heart disease in addition to high BMI. Bariatric surgery is the most effective treatment for morbid obesity in that it can result in improvement or complete resolution of obesity comorbidities. Fewer than 1% of individuals who meet the criteria of weight loss surgery actually undergo the procedure. It is advisable for severe obese patients to have surgery earlier to prevent the development of other medical conditions such as diabetes and hypertension. NIH guidelines for patient selection for bariatric surgery. BMI greater than 40 or a BMI greater than 35 with comorbid conditions. More than or equal to 100 lbs excess weight. Previous failed weight loss attempts. Bariatric surgery is an option for obese adolescents. It should be considered for an adolescent only after the patient has unsuccessfully tried to lose weight for at least 6 months. The candidate should have a BMI of 40 or more, be at least 13 years old for females and 15 years old for males, and have serious comorbid conditions. Bariatric surgery in adults aged 60 years or older is effective. However, older patients may develop more pre- and post-operative problems and achieve less weight loss than younger patients. Complications, risk and adverse effects. Negative effects of a bariatric surgery may be classified into true complications associated with the operation and adverse effects related to the alterations in upper gastrointestinal anatomy. Nausea and vomiting are common adverse effects. The patient can minimize their occurrence by eating a meal without interruption, chewing meticulously, never drinking with meals, and waiting 2 hours after consuming solid foods before drinking. The prevention of secondary complications of morbid obesity is an important goal of management. In 2006, approximately 40% of the patients who underwent the bariatric surgery developed complications within 6 months. Mortality from bariatric surgery is relatively rare. The mortality rate differs accordingly to the type of the surgical procedure. Assessment of the risks of weight loss surgery should include operative, pre-operative and long-term complications. The rate of complications in the early post-operative period, like wound infection, leaking from the stomach into abdominal cavity, leaking from staple lines or from Y connection, saline solution leaking from port, stomal stenosis, marginal ulcers, constipation, staple line dehiscence, pulmonary problems, and deep thrombophlebitis may be as high as 10% or more. Thank you for watching. Hope you guys like this video and please do like, share and subscribe.